founding president of the Italian Association for System Medicine and Healthcare, and active researcher of the Italian System Society. His wide research activity is deployed between the fields of medicine and systems, promoting a deeper comprehension of the system dynamics in genetic, epigenetic, biomedical, and biophysical processes. Overcoming the precision medicine model, Dr. Pristipino proposed a shift to a new perspective based on understanding of the role of multidimensional feedback processes in complex systems, where psychological, emotional, cognitive, and cultural variables invariably influence disparate biological process within every bodily system, with relevant medical and societal implications. Please, Dr. Pristipino.
Thank you very much. Thank you very much, and first of all to you, Professor Barile, for the kind invitation today with such a distinguished audience and participants, faculty. I hope I will be up to the level of this really outstanding meeting. So I will start from the last point of, that was raised by Michael, that's saying I will start with a narration, with a narrative. I will take you in a journey, not explaining much concepts, but take you in a journey around what's going on in medicine right now. What we are witnessing in those days is a big revolution. I don't know if you have, if you are aware of such messages like the books on the creative destruction of medicine, or a new era of precision medicine, or the presidential address of the State of the Union from President Obama in 2015, announcing a new breakthrough in medicine for personalization and individualized medicine. All this, in fact, was born. Can I ask you to shut down at least these lights just above the screen?
All lights.
Okay. If it's okay to shut it down. Okay. So, what's going on now is that this revolution, in fact, it's really very old, because it comes from a little piece of this big construction that is medicine that has been pulled out in some years ago. Well, all the story was born in the 1700s with this French doctor called François Boissier de Sauvage, who was the first to classify diseases according to clinical appearances, to clinical manifestations. And that was the basis of all modern medicine. While the problem is that later on, we tried to understand what was behind those manifestations. And what was behind the manifestation, it was the molecular medicine, which was born much, much later, in the end of the first half of last century. In 1949 exactly, with this article published in Science, where these scientists called for the first time in medical history a disease a molecular disease. This is very simple. You see something and you want to understand what's behind. But, well, this very simple thing, you will see where it is bringing us today. Well, of course, this very simple thing was saying we have one disease, so we have one mechanism that is not working properly. So was born the paradigm of one gene, one disease, one protein, one disease, and one treatment, hopefully. That was the main paradigm of all medicine until now, and it still is for someone. But let's take, for example, the Huntington disease. Huntington disease is a terrible disease that strikes the brain. As you can see in the upper part, this is a diseased brain as compared to the bottom one, which is a normal brain. It's hardly half of the first one. The brain is completely disrupted. And this is due to a very well-known gene mutation. It's a single gene which is mutated, and it's on the short arm of chromosome 4. And it's a sequence of CAG nucleotides that codes more or less with a more or less a huge number of these mutations occurring in this chromosome. But what's going wrong here that doesn't match at all with this paradigm of one gene, one protein, one disease, is that unfortunately we have more than one phenotype. That means that there are very different clinical manifestations, from very mild manifestations to very, very severe ones. So this means that this is something that is not working with our paradigm. Because how comes that the same identical mutation in the same gene translates into different clinical pictures? And the reason is very simple, that everything is not in the genes, that things are much more complicated than what we think. And of course the gene is mutated, but what is also mutated, it's all the apparel which is around the genes and that allow the genes to be expressed. This is the epigenetics, what is called epigenetics. As you can see, many other genes are mutilated or some other kind of alterations which impede the cell to translate what is written in the genes into protein. And this multiplies as this very part of epigenetics is controlled by genetics. It's a kind of a loop in which cause and effect is a little lost. Okay? So it's generating variable, linear, circular, and complex mechanisms inside the cells themselves and translating in different diseases. Therefore, coming back to our first paradigm, we have here that Huntington is not anymore a disease, but it's a bunch of diseases of what we call in medicine a syndrome. A syndrome is a clinical manifestations of different diseases. In fact, what happens is that a clinical diseases just take together different molecular diseases, which are now the diseases that we should pay attention to, that we should address. Well, and this is the basis for personalized medicine and for all the complexity of medicine today. Indeed, in this complexity, the systems approach has been breaking through. Thanks to technological advances of high throughput technologies that allowed us to have for an affordable price now complete mapping of the whole genome of each of us. As you can, this is a map of the genome of one single person with all the connections among genes, between genes. We have been able to build very complex maps and models of intracellular functioning. And that's not all, but we have been able also to categorize them in so different layers. That means that these multidimensional connections and multidimensional levels interacting each other. Well, this is changing our way of doing research. We have the classical in vivo human and animal models, in vitro human and animal models, that means cellular cultures mainly, but also now in silico models. With high performance computers, we are able now to build models of very high complexity to try to make experiments in a way that in biological system is impossible. That means to change only one parameter, keeping all the other constants. But those are not perfect, of course. It's all the difference that there is from, I am Italian, so and French, so I take the metaphors that are consistent with my origins, and it's like exactly like a menu. The difference from the menu and from what you eat. If you read the menu, you are not eating anything. So the difference between a model and what's happening in reality, it's all this. The difference from the menu and what you eat. The menu has to be refined as long as we try to understand what happens in reality and how much, to what extent the model matches reality. But in the meanwhile, what we discovered since the 40s of last century is that these kind of connections that we have seen inside the cell, it's also present in the whole organism. That means that brain, for example, is highly interacting with immune system, with the endocrine system, with the inflammation, with the cardiovascular system, with the gut, with all the microbes that are resident in the gut, and has a very important crosstalk with the neural system and immunological system. But also, this is a really very important step up done in the States by the collaboration between Joseph Lo Scalzo and Laszlo Barabasi, where we found that also diseases are connecting each other. It's not only the processes, but also the diseases, because many diseases, different diseases, share the same molecular pathways, and on the contrary, a same disease in different persons have very different pathways and molecular pathways. So the complications, as you see, and the complexity is raising up. So all these led us to the building of the idea of the complex phenotype. What is a complex phenotype? Is to simplify a Google map of the human being. As you see, we have to build for each layer, from the cell to the psychological and social and environmental point of view, maps of interactions of each process which is relevant to this very human being we are considering. And exactly like Google Map, those are levels as when you put satellite images over the real and the very map we design, just drawn map. You can tilt from one another, and that's exactly what this is, the complex phenotype. To put together all these layers and to try to choose which one is relevant for what you are observing, and in the same way keeping all the connections among all the layers we are observing. What is very interesting is that now it has been acquired that this Google map is a dynamic map, because all the relations are completely different from time to time. If someone would have taken this picture of me before this talk, and now it would take another one, he would see that the map has completely changed in just 15 minutes. So what's the consequence on the model we were speaking about before? It's that the clinical disease, of course, as you can see on the left side, it was the pictures I showed before. It's a system of different diseases, molecular diseases, which can be classified into different phenotypes. However, what is nice, it's very complicating things even more, is that a long time the phenotype can change and things can overlap. So each individual can pick up parts of the phenotype of other classifications at the time t0. And so in the time t1, you have the phenotype, the blue phenotype, or the red phenotype, or the green phenotype of part of them. So you see how difficult is the problem of individualizing medicine. And that's the winds of change are blowing very hardly now, because this discovery led us to change at the medical level, but also at the social level. And those two changes are somehow overlapped. But now, what's the key to change society and to be able to construct this new approach? First thing, it's important, the key thing is to flip our lenses of observation and changing, shifting from a reductionist way of building medicine, which has been the case up until now. And as you can see, we lost completely time, space, and context. And our medical treatment are, of course, disease-driven, aimed at normalcy, which means trying to giving response or understanding response of average populations, but never individuals. And it's addictive. That means that if I break up all the parts of the person with specializations and considering only isolated disease and not the relations among diseases, what will be is that I will give a treatment for hypertension, a treatment for diabetes, a treatment for anything, considering everything separated and just side by side. On the contrary, if I focalize on systems approach, on system science, I will try to focus on relationships between nodes and trying to understand how the characteristics of nodes change according to the relationships they acquire during time. That means that the medical treatments can be able to become individualized. We can be able to use one drug for multiple treatments. It will become time sensitive because we will understand how characteristics will evolve according to relationships. Space sensitive, context sensitive. There are many advances in cancer treatments right now which are focalizing on microenvironment of tumor and not only on the characteristics of the tumor itself. And it's synergistic, of course. So the first big shift, of course, if we have to make this shift, this change, is to change education. And of course, keeping an attention to a core curricula in university. It has to be changed radically because, of course, all our building of our knowledge is done on a reductionist perspective. The other interesting thing is that, as you see, this is a kind of simplifying complex phenotype building. You can see we have to build maps on the genetic network, maps of the biological network, of the clinical and environmental networks. There are also other layers that I will explain later, but all these networks have to be in relation one to the other. And this means a reclassification of diseases. This means that looking at relationships, we will assist to what we call a democratic aggregation of data. This is hypothesis-free, which is completely different from the models of developing now treatments and understanding of the human being. Because what we see right now that we have an hypothesis and we try to test this hypothesis with experiments. In this kind of building knowledge, we are observing data. Of course, we are choosing which data we will observe, and this is the second order science in this very aspect. But once we have chosen them, we just observe as how they aggregate and they separate and they segregate in different classes that are unknown until now. So it's hypothesis free up front. In the medical fallouts are new drugs that we will develop companion diagnosis tests. That means that we will identify patients that will benefit most from treatments, and also diagnosis and prevention. It will be a preventive way of addressing medicine, because we will try not to predict single events, but more the transition phases between, for example, health or disease, looking at how the whole complex phenotype is evolving around attractors. The scientific fallouts are very, very hard, because, first of all, we will have to reassess all the outcomes we know until now. Once we reclassify medicine, not anymore according to diseases, but to complex phenotypes, we will have to redo simply to rebuild all the evidence we have. The second aspect is that we will need new study designs, because up to now, randomized controlled trials are the reference for evidence generation, and instead we will need also, for example, studies on one single person. It will be enough. And even if it's not really a Galilean style of experiment, it will be science at any rate. And finally, also reconsidering the evidence hierarchy. Up to now, randomized controlled trials are the top of the hierarchy, are the best source for evidence, but in this new approach, this kind of hierarchy is no sense absolutely. The other point, which is important, is that the complex systems are so complex, involving the animal world, the relation with the animal world, the flora of the planet, and also economic subsystems. We know very well that low-income countries have worse outcomes than and life expectancy as compared to high-income countries, social subsystems, psychological subsystems, and cultural subsystems. All these are really weighting much on the complex phenotypes, individual complex phenotypes. This means that medicine will change and will have to change in an interdisciplinary way, and also, therefore, to interprofessionalism. But to build interprofessionalism, we need proper infrastructures. First of all, professional networks. We are already trying to build integrated platforms connecting hospital, primary care, patients, imaging, and but also sociologists. We also connect philosophers because of the need for the second order analysis. And just for this reason, this is a OECD report of this year. As you see, only in the upper part of the graph here, Poland, Norway, and Iceland are really ready to share electronic health records to build, to be used for research and clinical applications. A bunch of other countries are almost ready, but the vast majority of countries are still far behind. So this is a gap we will have to bridge in the next years. Of course, considering the complexity of individual to be answered, we need to build complex networks of care. And this we should address and treat these complex networks of care as living networks themselves, therefore considering also to complex phenotyping of the organizational level. And that leads us to a very big shift in way of organizing the networks and the cares systems, the healthcare systems, because we will have to shift to a vision-based, focused on collaboration and on market creation much more than on market dominance. There will be, but already the multinational drug companies have already well understood that it's not possible to go forward anymore alone, but they need very big collaborations among them. Of course, personalized care therefore need to be localized care. It means that if we need to pay attention to the individual, we cannot do it out of of their proper context. It means that we have to reach them, each individual, in the place where they are, to monitor and to draw their own environment. And this means also that we will have to build different kind of repositories. We still do not have the ideas very clear about that, but we will need to develop new models of gathering data. And all these need, of course, a watchful implementation of all these steps, in which the value per money, the value per money will be a central issue. We will have to have data about efficacy and about safety of these approaches before implementing them at a large scale. Of course, we also will need houses for complex phenotypization. That means that in your quarter, in your county, in your city, in your town, you will have the need of a place where to go and make complex phenotyping of yourself at a different time scale in order to follow your evolution. Networking in this way will also give the opportunity to bridge divides. First of all, at the geographical level, of course, the person with difficult access to care will be much easily followed, as well as low-income countries as compared to high-income countries. However, all this will need digital know-how from all people involved, not only the doctors and nurses and all care professionals, but also from patients. We do have already many wearable devices that can generate this big data time to time to be able to construct the complex phenotypes. Those are different kind of dedicated or less dedicated wearable devices, but also implantable devices. For example, pacemakers or defibrillators can be connected to Wi-Fi or to the internet to send informations to central repositories. And also, from the scientific point of view, we have research databases. We have to build specific research databases. First of all, that have to be interoperable. Then, not only among them, but also inside themselves. Because in a hospital, for example, we have so many sources of data that have to speak together and have to lump all this data together in only one figure. Of course, the Internet of Things will contribute to gathering of all this data, as well as, for example, I don't know if you have heard of Watson tools by IBM that is working with the artificial intelligence for supporting research but also clinical decisions. Regarding artificial intelligence, sorry for the color that is not very clear here, but of course the deep learning and the artificial intelligence approaches are those that are being developed. As you can see by this slide, more than 60 startups are using deep learning in healthcare as well as in many other, of course, fields. But all this bring up a problem of new forms of copyright. Copyright, of course, of models and in silico experiments and models. Of course, this has to be questioned also from the ethical point of view, how much this copyright can be applied to these models, because how is the right for anyone to own the human functioning? The other way around is artificial intelligence and machine learning. Of course, they also will have algorithms that will have to be subject to copyright, as well as software and expert systems to support clinical decision and research. Also, privacy is a big issue from the social point of view in this big change, because hackers can ransom individuals, but also institutions. There are more and more frequent attacks to hospitals. They block entire hospitals or networks and ask for money in change before freeing them. And this can also translate in terror attacks, because just imagine what can happen if one infiltrates the networks, building up complex phenotypes of persons, just completely changing approaches and conclusions. But also imagine what can happen if someone put their hands on a centralized control of all pacemakers of people. They can just kill thousands of people in the same way, in the same moment. But all these quantitative aspect of medicine, as we have seen with complex phenotyping, cannot go without a qualitative part, which is very typical of medicine. And that's a very important part, because, as you see, this is a research published on Nature by Fabrizio Benedetti from Turin in Italy, which is the most important expert worldwide on placebo effect, where placebo is considered as a qualitative stimuli on the person. This qualitative stimuli is translated in hormones and in neuromediators that influence deeply the mechanism of functioning of our own body. Therefore, what placebo effect is, in fact, is nothing less than self-fixing mechanisms. Therefore, all the qualitative part of medicine has to be put on this part. First of all, we will have to find a way of modeling and in some way quantifying also this qualitative part, always keeping in mind that there is a difference between the menu and what you eat. But it's important, therefore, a central place will take all the medical humanities, counseling, health psychology, health promotion, educational medicine, in all these kind of approaches. Indeed, being able to, for the first time, implement the real evidence-based medicine, which always has been thought to be the best external evidence, lumped with individual clinical expertise and patient values and expectations. But until now, we have just developed the first two, The third part has never been really implemented in medicine, and we will have to try to find some organizational and epistemological ways of implementing this part without losing the quantitative part. In fact, the personalized medicine is built up of predictive, personalized, preventive, but as we have seen until now, but there is also participatory. It's the fourth P of medicine. Just to say that we are not talking about poetry, is that, or at least only poetry, but this very recent report in the New England Journal of Medicine, you see that patients that have been involved in their care have better outcomes, both in mortality, in the bottom part, but also in the access to hospital facilities, as you see in the upper part. PRO are the patients that have patient-related outcomes. It means that for an active participation. This means a shift from a reactive model of medicine, that means I have a sickness, I try to react, and to a proactive mode in which patients have an active participation. I still have 10 minutes. This means that the model will change, will shift from the patient to be a passive subject of care to a partner in the cure process. This means that he's not necessarily the center of our attention of the cures, but what should be the focus is the network of the relations that goes around the care itself. This means that the transformation of knowledge shifts from the classical relationship between patient and doctor, which was one-to-one, to a networked, indeed, model of transfer of knowledge. And this means a new form of representation of patients. We have three main initiatives in the States, PCORI and the NIH initiative for precision medicine initiative, and in Europe, EUPATI, the European Patients Academy. All these bodies contribute to the building themselves from the side of the patients of pathways, clinical pathways, of guidelines, and also, of course, to the relationships, to the care relationship between the doctor and the patient himself. And finally, and this will be the end of my talk, there is the costs issue, which is a very, very important one, because it will give the possibility of all this to be implemented or not. The first ingredient to make the cake working is a political endorsement. As showed President Obama himself when I was talking before he addressed this issue in his presidential talk in 2015 on the State of the Union. And he presented himself. Therefore, we need a very strong political endorsement, because political decisions have to be made to change very deeply the way we are constructing health and medicine. The individualized treatment development is a problem of very high cost, because the market, of course, shrinkens and the costs raise for each individual. Therefore, we will have to very carefully assess the balance between costs and value. The other one possible issue is to make private-public partnerships with co-financing that will allow negotiated price for individualized treatments. Of course, there are drawbacks. For example, that of course costs per procedure, both diagnostic and therapeutics, will rise. However, the possibility of higher success of therapies, more timely therapies, and improved outcomes, as well as a decrease of side effects, less diagnostic procedures, yes, high heterogeny, shorter times to remission in patients who are sick, and reduced legal costs because of reduced aggressiveness between patients and doctors will reduce overall costs. So as you see, I have tried to do an overall journey on what a very simple and tiny change seemed at the beginning, showing the butterfly effect really exists, because a very little change upfront resulting in a very, very big wind of change. Of all this, we will speak about in our next upcoming Congress here in Italy of our association, and we'll go deeper into each aspect of this one. You are all invited, of course, and you can find the details on our website. Thank you very much for your attention.